Welcome, everyone. It's wonderful to have you join us. We are gathering today in this wonderful, crazy way that we now gather on screen to talk about some of the common concerns, issues, and experiences of young women who are in the process of being treated for breast cancer. I'm Debbie Homolsky, and I am a retired nurse from the Breast Care Center and UCSF. And I have the distinct honor today of being on screen with my colleagues who are going to put together some core information that we really hope to be of use to you. So with me this evening is Dr. Jo Chien, who is a medical oncologist in the Breast Care Center at UCSF, who specializes in breast cancer and has both clinical and research interests in HER2 positive breast cancer and in working seminally for this particular conference with young women and all of the issues and concerns that come up around treating breast cancer in that setting. And she's going to be giving us collectively an introduction to some of the core issues and that come up in medical oncology treatment that are common to many young women experiencing diagnosis and treatment. And in general, today is an overview and a giving of resources all in one place. Obviously, in an hour and a half, we can't cover everything that's there to be covered. With us also today is Dr. Mindy Goldman, who is a gynecologist and a professor at UCSF and director of the Gynecology Center for Cancer Survivors and At-Risk Women. So there's an innovation here, which is really looking at the specific women's health issues that come up in the course of being treated as a young woman for breast cancer. And she will help bring us into that world. And Kathleen Cavanaugh, who is an integrative oncology nurse practitioner at the UCSF Osher Center for Integrative Medicine. And if there are words in there that need defining, that's part of what she'll be talking about today. But she brings deep personal wisdom to her practice. And integrative medicine is really about looking at the kinds of coping strategies that get you through. And I think from all three speakers tonight, that's really at the heart of what we want to begin to address here, which is what kinds of wisdom and information and stories can you bring with you to make this a less difficult, although it is difficult, to give you some tools in the tool belt to help along. The way this evening is going to work is each of these speakers will speak for about 20 minutes-ish in their area of expertise. And then at the end of all three speaking, we will have hopefully about 25 minutes at the end for questions and answers. Please, as they are speaking, write out your questions in the question and answer section, and I will be looking at them over the course of time, and I will moderate the question and answer session at the end. This entire seminar, if you want to call it that, webinar, is going to be recorded so that anybody who comes to it and anyone in the future would have access to being able to look at it. If there were parts of tonight that were relevant for you and important for you, you will have access, and you can point out those access points to family and friends or anyone else that you know. So without further introduction, again, welcome. And the first person we're going to hear from this evening is Dr. Jo Chien.
Thank you, Debbie. Great. Can you hear me? All right, I'm going to share my screen. Okay, so thank you everybody for joining tonight. I'm going to start off by spending 20 minutes just giving an overview of what makes breast cancer in young women different. So I think first we should define what is a young woman with breast and what defines young woman. And to be honest, there really is no universal definition. Most studies probably define it as under 40 and other studies under 45 at the time of diagnosis. But as you'll see in some of the studies we'll discuss tonight, subset analyses have looked at women under 50. So when looking at the data and reading articles, make sure that you look to see how they are defining young women. In the US, about 27,000 breast cancers a year are diagnosed in patients under age 45. That makes up about 11 to 13% of all breast cancer diagnoses in the US. If we were to just look at cases under age 40 at the time of diagnosis, that would be about 12,000 cases a year, making up about 5% of all breast cancer diagnoses. The incidence of breast cancer is in women diagnosed at the age of under 40 is slowly rising over time. The good news is that survival in young women continues to improve. And in fact, over the last 30 to 40 years, we have improved breast cancer survival by at least 30%. This graph here is from the SEER database, which is a database looking at epidemiology and endpoint outcomes in the United States. And as you can see here on the x-axis, it's looking at 1975 to 2019. And the top blue line shows the incidence of breast cancer in women under age 40. And you can see that line is slowly creeping upward. For those under age 40, we see a 0.5% increase per year since 1994. If we were to look at age less than 50, 0.3% increase per year since 1994. And for those 50 to 64, for comparison, it's 0.1% increase per year since 2006. As I said, the survival is improving, and this bottom line in green shows the mortality from breast cancer since 1975. And in the young women, the good news is a 2.9% decrease in mortality per year from 1986 to 2010. So even though a diagnosis of breast cancer is difficult for all women, we know that there are unique challenges for young women in particular. One of the most common challenges includes early menopause or medications that really deplete a patient's estrogen and the side effects from that. This can be caused by chemotherapy. It can be caused by medications that we give to intentionally suppress the ovary production of estrogen. This causes both short-term and long-term effects from lack of estrogen, short-term being hot flashes, night sweats, dryness, hair thinning. Long-term effects primarily being impact on bone density and cardiovascular risk. Another very common and stressful challenge for young women is the impact of a diagnosis and the treatment on fertility and family building. You know, oftentimes at the time of a breast cancer diagnosis, a young woman is also planning to build their family. And the good news is that we work very closely with our fertility specialists. Here and across the country, we're very supportive of fertility preservation prior to starting breast cancer treatment. Our reproductive endocrinologists have what they call a random start protocol now, where they can start egg harvesting at any point in a woman's cycle so that they can finish the egg harvesting process in 2 weeks. And that's great for patients where we need to start chemotherapy quickly. In addition, women who are done with their acute phase, they're on maintenance hormone therapy, and the recommendation is 5 years. There's a lot of stress around when they can get pregnant. and when is it safe, and is it safe to take a break from their hormone therapy? These are all questions that we don't have clear answers to, but working with our reproductive endocrinologists, this is a very common scenario that we're very well versed in. Another common challenge is navigating genetic testing, and if there is a positive genetic mutation that has predisposed the patient to getting breast cancer, this can impact decisions about surgery. And now there are certain medications we give if a patient is BRCA positive, and also impacts fertility preservation for patients who do carry a BRCA mutation or other mutations. Our reproductive endocrinologists like to harvest more eggs and freeze more eggs or embryos in order to be able in the future to select out the embryos that do not carry the gene, if that is the patient's wish. Other things like role functioning. Many of our young patients have young kids at home, and we know that mothering does not stop because of cancer or chemotherapy, and navigating that and how to be a partner. Oftentimes young patients are just at sort of the peak of their career. Their career is really taking off, or they're starting a new school program or making a switch in a career, and a diagnosis and treatment can be very disruptive to that with long-term effects. Heightened concern about body image, and for those that are single, dating, and stresses, unknowns about finding a partner in the future, and intimacy and sexual dysfunction. One that doesn't get talked about a lot, but is particularly relevant in the young population, is financial toxicity, not just because their careers may be put on hold and the long-term implications of that, but this is an age group where sometimes insurance status is unstable and absorbing the cost of medical care. And we also know that anxiety and depression is very common in this age group. And we work very closely with our psychology and psychiatry colleagues. So I have here on the right, just this is a comprehensive cancer center here at UCSF, and we work very closely and collaboratively with our colleagues in other disciplines. So your team could consist of many of these or all of these specialties. Obviously oncology, including surgery, plastics, radiation, reproductive endocrinology, gynecology, genetic counseling, psychology and psychiatry, integrative oncology, survivorship, nutrition and exercise. I forgot to put in physical therapy is critical to this program after surgery, and also due to some of the chemotherapy side effects, and social work. Breast cancer in young women is often associated with higher risk clinical features. We know that women who present initially, who are young, come in with larger tumors, more often with node positive disease, high grade tumors. They often present at a higher stage and with more aggressive subtypes of breast cancer, such as triple negative and HER2 positive. The graph on the right just shows the distribution of stage based on age. So women under 40 are represented here in this blue bar, and 40 to 64 in the green bar, and 65 to 74 in the pink. Localized breast cancer is cancers localized just to the breast. So that's usually our stage 1 cancers. And you can see that the younger women are less likely to present with localized. Regional is node positive, and more young women present with regional disease, and even more with distant disease. Even when we control for these high-risk features, we do know that younger age is an independent risk factor and does predict for higher risk down the road. However, what is really interesting is that in more modern studies, for example, our HER2 positive studies where patients are being treated with trastuzumab, which is a HER2 targeted therapy, we're not seeing that difference between outcomes based on age. So young women can do just as well as older women, which to me is really exciting, because what that says is if we can find the right drugs for the specific mutation or the specific subset, we can really change outcomes for our younger women. We now know more and more that breast cancer in young women actually has a distinct biology. Here on the left I'm showing you the distribution of the breast cancer subtypes based on age. So ER positive, HER2 negative tumors are represented here in the blue bar, triple negative in the purple, ER positive, HER2 positive in the red, and then ER negative, HER2 positive in the green. The less than 40 here in the left, and then the middle bar is 40 to 49, and the right bar is over 50. And what you see is that as patients get older, they're more likely to present with ER positive, HER2 negative cancers. And these are often more slow growing. And we know even within the ER positive tumors, the younger patients tend to have what we call luminal B tumors, luminal B subtype, rather than luminal A subtype, which does have a slightly more aggressive biology. The triple negative cancers here in purple, you can see, are more common in the young patients. They're in the African American population, it's even higher than this 23%. And that the incidence of triple negative decreases with age. HER2 positive is also more represented in the young population. So if you combine the ER negative HER2 positive and the ER positive HER2 positive group, in the under 40, HER2 positive patients make up about 40% of all 28% of all breast cancers. And that breakdown decreases with age as well. So the right panel here is just saying when we send these genetic signatures, such as oncotype or mammaprint in our ER positive tumors. Many of you may be familiar with this. When we send this to help us determine, does the patient need additional chemotherapy? We are finding that in our young patients, noted here in blue, that more often they have high risk scores compared to our older patients. So both of these graphs really tell us that the biology of cancers developing in young women looks different than in older women. And one really interesting finding that I just wanted to note here for, because I think it's fascinating. This research comes out of University of Colorado, and it's on postpartum breast cancer. And these are cancers that develop, the definition also is variable, but 5 to 10 years from the last delivery. And we find that these tend to be higher risk. And the question is why? And there's some research showing that after pregnancy and after lactation, when a woman is weaning, there's a lot of remodeling in the breast tissue. It almost looks like wound healing. And what they have found in animal models and in some breast specimens is this influx of suppressive immune cells. So it sort of looks like an immunosuppressed breast. They also see some increased lymphatics and blood vessels and some collagen. And so the thought is, could this kind of remodeling of the breast explain why maybe we're seeing some more lymphovascular invasion or lymph node involvement? And there's some research going on trying to target those mechanisms that might be very effective treatments in the future for young breast cancer patients in particular. It's really fascinating. How does age impact treatment recommendations? Well, in the past, tamoxifen was the standard hormone therapy for young women. Over the last decade, we've learned that when we add ovarian suppression, meaning we shut down the ovary production of estrogen, when we add that to tamoxifen, we can improve outcomes. So lower recurrence rates, improve survival. We now know that when we add an aromatase inhibitor with the ovarian suppression, that further improves outcomes over tamoxifen and ovarian suppression. We see this in patients who receive chemotherapy. The greatest benefit is seen in women who are under 35 and who are HER2 negative. The study here, the panel here on the right, is showing the side effects reported in the study that looked at tamoxifen versus ovarian suppression and tamoxifen versus ovarian suppression in AI. And I just want to call out one thing here, and that's depression here in a red box. And in all three arms, nearly or over 50% of patients are reporting depression. And it's just so important to note that this is really common. It's important for patients to know that, for providers to know that, for us to talk about it, and for us to talk about, referrals to psychology or starting medication. For the sake of time, I'll leave the other red boxes, but we do see more osteoporosis with the AIs. In all three arms, we see vaginal dryness, decreased libido, hot flashes. Do younger women benefit more from chemotherapy? We do have a lower threshold to give chemotherapy in our younger women. As I was mentioning before, we use these molecular tests, Oncotype and Mammoprint, to help us decide who needs chemo on top of the hormone therapy. And there have been trials that have looked at the patients who have intermediate Oncotype scores or Mammoprint low risk scores. And in all of these trials, it's very clear that women over 50 do not benefit from chemotherapy. But what has come out in all of these studies is that there is a benefit, or at least there is a lower risk of recurrence in our women under 50 or 50 and younger. The question is why, and it's very curious because sometimes we see this benefit late at 8 years, and we know that usually benefit from chemotherapy is seen in the first 5 years. There's been a lot of talk and interest in the idea that the reason we see slightly lower risk of recurrence in our younger women who get chemo is not because of the chemo direct benefit. It's because chemo is inducing ovarian suppression in these young women. And it's really that additional hormone therapy that is offering benefit to these women. In these studies, most of the women just got tamoxifen. So those that went into menopause from chemo benefited from ovarian suppression plus tamoxifen, which I just showed you in the other slide, is better than tamoxifen alone. This is further supported because we see this benefit greatest in women over 40 and less so under 40. And the reason is, we think, possibly, that those over 40 are put into permanent menopause with the chemo, and those under 40 recover their ovarian function because they're younger. It's also worth noting that we know in our young patients that they are more likely to discontinue their hormone therapy due to side effects, most likely. These are data from the soft text trial, which looked at the ovarian suppression and the oral, either tamoxifen or AI. And you can see that about 20 to 30% of patients at 4 years have discontinued both their oral endocrine therapy as well as their ovarian suppression, shown here in the right panel. And those that are under 35 in the blue line are more likely to discontinue than those that are 35 and older in the yellow line. This was also seen in a cohort from Kaiser in Northern California in nearly 9,000 patients, where they saw that those that were under 40 were more likely to discontinue or be non-adherent, meaning not taking it as prescribed, than those 40 to 55, and those 55 to 65 were very adherent. And I just want to make a side note that there are hormone therapies in development. One in particular is called an oral SERD, oral selective estrogen receptor degraders. It's a novel class of medication that degrades the estrogen receptor. These are now in phase 3 trials in the metastatic setting. The side effect profile looks excellent, looks to be much better tolerated than AIs. And there's some thought maybe you don't even need to be on ovarian suppression with these drugs. So we are studying this now in the early stage setting. And, if all goes well, this might be an option that's better tolerated for early stage breast cancer in the maintenance phase. And I'm going to close with 2 slides that highlight a couple new advances that are really exciting that will impact our young women. The first one is in triple negative. So on July 26th, the FDA approved pembrolizumab, which is an immunotherapy for early stage triple negative breast cancer. So pembrolizumab is what we call a checkpoint inhibitor, an anti-PD-1 antibody that stimulates our immune system to help the chemotherapy kill the cancer cells more effectively. And when you give this drug, this immunotherapy with chemotherapy before surgery, we see that we can increase complete responses by 7% compared to chemotherapy alone. And we are now seeing that results in reduced distant recurrences at 3 years. And that reduction is 7% at 3 years, which is really impressive for triple negative. The side effect profile looks different, mainly autoimmune side effects, which we have to monitor for over time. And the second one I want to highlight is for BRCA patients. So the Olympia trial, which was conducted in 1,800 patients, looked at a class of medications called Parp inhibitors. So Parp is an enzyme that that repairs DNA, and patients who are BRCA positive are very dependent on that enzyme because they lack the BRCA protein. And so these drugs that inhibit Parp, then these tumors cannot repair themselves. So they're very effective at killing these tumor cells. When this trial randomized patients who are high risk and BRCA positive, either BRCA1 or BRCA2, although most were most were triple negative and BRCA1. And they randomized them to 1 year of olaparib or placebo. And they saw at 2.5 years of follow-up that they were able to reduce the risk of recurrence by 7%, which is really large for our research, for our studies. And this drug is very well tolerated. Main side effects are anemia and count suppression. We studied this as a single agent in the neoadjuvant study in BRCA1 or 2 patients who are triple negative in the NeoTALA study. And patients received 6 months of the Parp inhibitor talazoparib, no chemotherapy. And they found that 49% had complete responses. And that's pretty comparable to what we would see with chemotherapy alone. So that's really exciting. And there could be a scenario in the future where BRCA patients, triple negative, may be treated with Parp inhibitors by themselves. And finally, so to conclude, I want to say the biology of breast cancer in young women is different than the biology of breast cancer in older postmenopausal women. Understanding these distinct biological differences will be critical to identifying new targets and treatments for our young patients. But it's so important to prioritize the tolerability of our treatments, not only to improve the quality of life and survivorship, but also for treatment adherence, which may impact long-term outcomes. So in summary, we're making lots of progress. Already there are trials and subset analyses within trials that are specifically looking at outcomes in young women, which is a new thing over the last 5 to 10 years. We have many new drug approvals for high-risk subsets, which will definitely impact outcomes for young women. And we now have focus on patient-reported outcomes and quality of life as a meaningful research endpoint within all of our research studies, because we understand that tolerability is just as important as efficacy. That's it. Thank you.
Thank you so much, Dr. Chien. And I just wanted to say to everybody who's on screen with us, it would be wonderful if you could put your questions. We've seen the ones that are in the chat, they're there, and we'll come back to them. We would really appreciate it if you put future questions into the Q&A so we have them all in one place. That would be really wonderful. You don't have to change anything about the few questions that are already in the chat. And now I'm thrilled to welcome, for all of us, Dr. Mindy Goldman.
Okay, thanks so much. I'm really happy to be here. And I am, let's see. So hopefully people can see that okay. What I wanted to talk about is it's kind of going off and talking about some of the issues that Dr. Chien talked about, but really talking about it more from the eye of being a gynecologist and how I work and help women with breast cancer in terms of some of these specific issues. So it's important to realize there are many, many women's health issues that are related to cancer in general, chemotherapy-induced menopause, fertility preservation, safety of pregnancy after breast cancer, what are safe contraceptive options, tamoxifen issues, management of menopause symptoms, what's safe, what's not safe, treatment of aromatase inhibitor induced vaginal dryness, who really needs to get their ovaries out in the setting of breast cancer, and then treatment options for low libido. And I'm going to try and hit on most of these, and happy to answer questions about others that I don't. One of the things to realize is that sometimes some of the menopausal hot flashes are more severe in cancer survivors than we tend to see in general menopausal patients. And why is that? Well, sometimes for breast cancer patients, they may end up getting their ovaries out as part of their breast cancer treatment. Certainly that's less common in young women, but sometimes it happens. And when that does happen, there is the immediate onset of surgical menopause. For premenopausal women were having nice normal menses before they get before their cancer diagnosis, if they get chemotherapy, typically the chemotherapy will cause ovarian shutdown. I'm going to talk about whether it's permanent or not, but when you immediately shut the ovaries down, the symptoms tend to be more severe. We also see it in older women who were taking hormone therapy. They tend to abruptly stop their hormones when they're diagnosed with breast cancer. And then we know with certain drugs like tamoxifen, more with tamoxifen than aromatase inhibitors, but hot flashes are very common. One of the questions that a lot of my patients will ask me is, when I get chemotherapy, is it permanent or not? And Dr. Chien touched upon this. And we know that it is more common with the typical chemo agents that we use for breast cancer for women over 40 to have permanent ovarian failure post-chemotherapy. It's important to realize, though, that sometimes we can see periods return 2 years or even more after finishing chemotherapy. So if you get chemo and you haven't had a period for a long time and all of a sudden you start bleeding, the very first thing I recommend is checking an estradiol level to see if someone's ovaries have recovered. It's important to realize that even if someone gets their periods back after chemotherapy, that doesn't necessarily correlate with the ability to get pregnant. And we know that there are long-term ovarian effects, and that even women who menstruate post-chemotherapy are still at risk for undergoing premature menopause. So the chemo agents that we use, we know have sort of long-term effects on the ovaries, long-term cytotoxic effects in women typically go into menopause earlier. The average age of menopause in the general population is 51, and you can see that a number of years earlier for people who get chemotherapy. So what I see a lot in my practice is people coming in with all of these hot flashes from chemotherapy-induced menopause, or if they had to have their ovaries out, and they want to know, how do we treat that? And one of the things that I really try to tell people is you don't have to feel like you need to suffer. Certainly, hormone therapy is not an option. Certainly for people with hormone positive disease, with triple negative disease, and people have been doing well for long periods of time, 2 years or more, then it is reasonable to talk about hormone therapy. But in hormone positive disease, it's a contraindication. There are a number of alternatives to hormones, low doses of a number of the antidepressants, all of these that are listed here. Venlafaxine, the trade name is Effexor, has some of the best data. I'm going to talk about that. And then gabapentin, I'm going to talk about that because that also has some of the best data. There's a new drug that was added to this list, oxybutynin. That is used, it's actually an overactive bladder drug for people who have a lot of urgency and frequency. And there've now been some randomized controlled trials showing its benefits in reducing hot flashes. Now, the interesting thing is we don't know exactly what causes a hot flash. And we think there may be some temperature regulation zone in the brain. And the only thing all these diverse drugs have in common is that they can cross the blood-brain barrier. None of these, it's important to realize, none of these are FDA approved as a treatment for hot flash, except for one that's a brilliant marketing ploy, paroxetine, which is Paxil. Most people have heard of Paxil as an antidepressant. Well, the lowest dose that comes for depression is 10 milligrams. and they studied a 7.5 milligram dosing for hot flashes, found it effective, got it through the FDA, and changed the name of the drug to Bristol so women don't have to think that they are taking an antidepressant. I want to go through the big take home with some of these medicines is that the doses are very different than what the drug is typically used for. So I mentioned that Effexor and gabapentin have some of the best data, and these are two of the most common drugs that we use. And for Effexor, when our colleagues in the psychotherapy world use it, sometimes they'll go up as high as 375 milligrams a day for depression. For hot flashes, 75 milligrams is the most effective dose. The lowest dose it comes is 25, and that's scored and can be cut in half. There are long-acting formulations that are 37.5 and 75 milligrams. And so I start people low and work their way up to whatever dose they need, telling them that they won't get a benefit above 75. Gabapentin in high doses is used to treat neuropathic pain, certainly in some of our breast cancer patients who have chest wall pain after mastectomies. But in low doses, it can help with hot flashes. And the big thing with this one is it causes sedation as a side effect. So if someone is having more of their hot flashes at night and disrupting their sleep, gabapentin is usually used first line. The most effective dose, 900 a day in divided doses, but you can start as low as 100 or 300 depending on how sensitive someone is. I try to tell people, remember lifestyle interventions, wearing loose layered clothing, certainly stopping smoking for many, many reasons, but also for hot flashes. Certain people have triggers like caffeine, alcohol, spicy foods. Exercise regularly is important, although sometimes exercise can actually worsen hot flashes, but on a regular basis, it's actually helpful. Fans, reducing stress. The theory is that you're narrowing this thermoregulatory zone within the brain. And I think for mild hot flashes, some of these lifestyle interventions can be helpful. Fertility desires. Dr. Chien again touched upon this, but studies show that 50% of premenopausal breast cancer patients are worried about treatment-induced infertility, and almost 30% of patients with breast cancer make cancer treatment decisions based on their fertility desires. The best option and the most successful for achieving pregnancy is by seeing our reproductive endocrine colleagues prior to getting chemotherapy and doing IVF and freezing either eggs or embryos. That certainly has the most success. Now, some women don't have access to that for cost, or sometimes that may not be appropriate. As Dr. Chien did mention, they can do a short cycle pretty quickly, but if that's not appropriate, other things that are being looked at, with those studies that looked at the benefits of ovarian suppression in terms of improving cancer outcomes, they have also looked at the benefits of giving ovarian suppression shots prior to chemotherapy to see if that improves fertility outcome. And so the theory is that you put the ovaries in a resting state, and there are some preliminary studies that suggest that this improves the likelihood of getting menses back, and that it does improve fertility. And there are ongoing studies kind of looking at it all, sending people, if they can, for IVF and freezing their eggs or their oocytes or embryos, and then potentially giving them a Lupron prior to chemotherapy to see if we can maximize fertility outcomes on that basis. What about pregnancy after breast cancer? There are many trials that show pregnancy is safe. Typically, recommendations are to wait at least 2 years disease-free, but that's based on oncologist recommendations. For women who are on tamoxifen and the oncologist has said it's okay to try and get pregnant, there is a washout period that you want to do. Minimum is usually 2 months. Most people will recommend at least 3 months. And then the recommendations are to resume tamoxifen postpartum to complete whatever treatment course was recommended. We don't have as much long-term data whether interrupted courses of tamoxifen are as beneficial on cancer outcomes as continued uninterrupted treatment, but I think we're starting to get data because this is certainly something that fertility is a big issue for so many patients, and this is something that we are recommending. It's important to realize postpartum tamoxifen can slow milk production and is not recommended for breastfeeding. Contraceptive options. If someone has hormone receptor positive breast cancer, you want to avoid any forms of hormonal formulations. Certainly hormonal formulations are the most successful, but again, should be avoided in our hormone receptor positive disease. This is really important because a lot of young women do end up on tamoxifen, and if they're not on ovarian suppression, it's important to realize tamoxifen alone can affect menses, and upwards of 50% of people may have changes in their menstrual cycle. Now, certainly that's going to be affected by if they got prior chemotherapy, but people have irregular menses. There's oftentimes a misconception that they may be going into menopause, and tamoxifen is actually chemically very similar in structure to the fertility drug Clomid, and tamoxifen actually works as a fertility drug. And our colleagues in the fertility practice sometimes use tamoxifen as an ovarian induction agent when breast cancer patients are coming to do IVF and freeze their eggs or embryos prior to chemotherapy. So women need to realize when they are on tamoxifen that that is working as a fertility drug. And a great contraceptive option, if it's needed, is the copper IUD that's called the Paragard. There are a lot of women will ask about the hormone IUDs. That's classically the Mirena. There's a couple others, Skyla and Kylena. And there are still controversies about whether that is safe in the setting of hormone positive breast cancer. Any form of barrier method is okay. And then a new option that was just FDA approved is Phexi gel, and it creates an inhospitable environment for sperm to get inside and for implantation. And so I often in my breast cancer patients will recommend, if they're not interested in an IUD, using condoms with this new Phexi gel. The other area that I see is very, very common in breast cancer patients that I talk to people a lot about is sexual side effects. And certainly there's lots of reasons for this. Cancer surgeries can cause pain and affect body image. Radiation can cause scarring, pain. Chemotherapy can cause neuropathy with decreased sensation, which may affect arousal. Induced menopause with hot flashes and vaginal dryness make people feel less sexual. Hormonal therapies, I'm going to talk about this, but the aromatase inhibitors specifically cause marked estrogen deprivation, and the vagina and vulva are very estrogen sensitive. Pain will oftentimes lead to decreased desire. Cancer treatment pain may affect sexual desire, and as well as stress, anxiety can affect desire. Orgasm difficulties, sleep difficulties also will typically affect women's sexual desire. So what do? I always say that in general, you want to fix the things that you can fix. So I want people to understand why we see so much of this. And this is particularly a problem in breast cancer patients who are on aromatase inhibitors. So when women are on tamoxifen, the way that that drug works is it competes with estrogen at the receptor binding site in the breast, preventing activation of that receptor. So it's an anti-estrogen at the level of the breast. Aromatase inhibitors work entirely different. They prevent the action of this enzyme called aromatase. And enzymes convert one substance to another substance. And aromatase functions to convert male hormones that all women have, androstenedione and testosterone, into these weak estrogens. Not the estrogen you check if you go to the lab. When you go to the lab, you're checking ovarian production of estradiol, which is the strong form of estrogen. Aromatase inhibitors shut down peripheral estrogen, which is primarily these weak forms of estrogen, but they do contribute to the body's overall estrogen, total estrogen. And that's how they work as a cancer drug, by suppressing all estrogen production. Aromatase is present in many cells in the body, primarily fat, so heavier women have more peripheral circulating estrogen. That is why they are at risk for estrogen-dependent cancers like uterine cancer. But we see aromatase in fat, muscle, brain, breast, and in the ovary. And if the ovaries are working when someone takes an aromatase inhibitor, what happens is the ovary senses that a drug's trying to shut it down, and the ovary sends signals back to the brain. The brain sends signals to the ovary that cause the follicles to grow and produce estradiol. So you cannot use aromatase inhibitors in a premenopausal women because they're working as a fertility drug. They stimulate production of estradiol from the follicle. So if you're going to use them as a cancer drug, you have to shut the ovaries down. Now, if you think about it, when you're taking an aromatase inhibitor, you're more shut down than menopause. So when we see menopausal women, plenty of women come in saying they have vaginal dryness and pain with sex. It is much more severe in women on aromatase inhibitors because you've shut down all estrogen production throughout the body. The vagina and the vulva is very estrogen sensitive. On the mild end, I'll see patients who will say, it hurts when we have intercourse. On the extreme end is people can say, I'm sitting and my vagina feels like sandpaper. This is a really, really significant problem. So how do you treat it? First line therapies from National Comprehensive Cancer Networks, all in North American Menopause Society, all recommend over-the-counter options as first line. There are many things, moisturizers, oils, topical vitamins, and suppositories of soothing agents, pH balanced gels, soothing agents for vulvar pain, topical anesthetics like lidocaine for pain along the opening, lubricants for sexual activity, both water-based and silicone. Vaginal dilators can be used to help stretch the tissue and figure out what hurts and what doesn't hurt in a non-sexual setting. Many of these things they're not going to change the tissue, but if you use them enough, they can provide relief. Moisturizers are recommended to be used on a regular basis. Lubricants are recommended to decrease pain with friction associated with sexual activity. I tell my patients on aromatase inhibitors, who thinks about their vagina, right? No one thinks about it. You want to have sex, you have sex. Unfortunately, when you're on these drugs, if you want to use the vagina, you have to think about it. What about vaginal hormones? Well, the benefits of hormones are you're targeting efficacy directly to the tissue with minimal systemic absorption and fewer adverse effects. How do they come? They come in suppositories, a ring, and a cream formulation. In general, cream formulation should be avoided in breast cancer patients in the ways that we typically prescribe. That is because there are some studies that suggest that it may cause a rise in systemic levels. The surface area is greater. When you push a bunch of cream up inside in the vagina, there's a greater surface area that could lead to potential absorption. It is, however, safe if there's one little spot on the outside vulvar tissue that's thin, that I may have someone rub into the area 2 or 3 times a week, that's not going to cause absorption. In limited trials, looking at the suppository and ring formulation, those are thought to have minimal systemic absorption and we think are likely safe to be used in breast cancer patients. Other things that people will ask me about, what about the laser? It's called the Monalisa. It acts to improve collagen production in the vagina. So it causes micro trauma to the vaginal tissue, and then you get new blood supply, connective tissue coming in to cause healing. It was approved by the FDA in 2014 for skin resurfacing, not for vaginal dryness or sexual dysfunction, and it's being used off-label for that, out of pocket. It requires 3 treatments in physicians' offices. It's pretty expensive. There's some thought that for breast cancer patients on AIs, they might need more than 3 treatments, not covered by insurance. The FDA has put out warning statements for the potential for burns, but I think really, in the literature, there really isn't an excessive, there's not burns that have been reported in amounts that are concerning. I think the concerns were that they are doing this without getting FDA approval. There are many, many ongoing trials now looking at the Monalisa. There are also a number of other devices. There are other devices I need to finish up pretty quickly. But again, none of these energy devices are specifically approved, but they all do the same thing in causing micro trauma and then new blood supply and connective tissue coming in. Painful sex, I just want to mention there are a couple drugs that are FDA approved specifically for painful sex. Ospemifene is in the same class of drugs as tamoxifen. It has not been studied in breast patients and it's contraindicated. Prasterone or Intrarosa, it was FDA approved in 2016. It's a vaginal DHEA, which is a precursor to testosterone. There are no safety trials currently for breast cancer patients on aromatase, but it is the only drug that doesn't have a big black box warning. The last area is 2 quick slides on low sex drive. You want to treat the dryness first and sex drive after. If it hurts to be touched or have penetration, it will affect desire. Testosterone in non-cancer patients, there's several trials showing improvement in sexual functioning with testosterone patches in postmenopausal women with low desire. It is non-FDA approved, but there are now consensus statements about using this. There is limited data and questions about safety in breast cancer patients. There are 2 drugs that are new that are FDA approved. They are FDA approved in premenopausal women. One is called flibanserin, the other is bremelanotide, and they work centrally in the brain, in the areas of the brain that are responsible for sexual excitement and sexual inhibition. They can be obtained off-label for postmenopausal women, so if you're on ovarian suppression, and they are both approved for hypoactive sexual desire disorder. When they are used off-label, they have to be obtained in specialized pharmacies in the country that will provide them at lower cost. Pelvic floor PT for vaginal pain disorders, dilators, as I mentioned, and then I work closely with sex therapists. Treat what you can. I always tell people we want to treat stress, fatigue, underlying mood, anxiety, pain, lymphedema, assess for medications that could be contributing, sleep issues, dryness, encourage regular exercise, healthy diet, and work on any relationship issues that could be contributing. The last slide is, I get a lot of questions about who needs to get their ovaries out. Certainly if someone carries a genetic mutation that increases the risk of ovarian cancer like BRCA, there are specific NCCN guidelines when we recommend removal of the ovaries, and we do a very specific risk-reducing surgical protocol looking for microscopic disease. If someone has early stage breast cancer on tamoxifen, clearly no. If someone has hormone receptor positive cancer and are on long-term aromatase inhibitor therapy, and when they finish their therapy, there is minimal chance of their ovaries waking up that would provide them with health benefits, I will typically say, why come in and get a shot every month when you can have your ovaries out? So in that situation, the answer would typically be yes. And I know I went over and I'm sorry about that. And I'm happy to answer questions after. So thanks very much. I'm going to stop sharing my screen.
Thank you so much, Dr. Goldman. And, you know, we have enough information to go on for days, but I want to welcome Kathleen Cavanaugh to the screen and let everybody know that there are many rich questions in the Q&A. And Kathleen will be with us until about 7:15, and we will have about 20 minutes to do our best to start with the questions, and we will send you follow-up information by email.
Okay, I'm going to go ahead and share my screen, and I'm pretty good at being succinct and we'll try to get us to the question and answer section. So I won't read this definition. Everybody can read it, but it's the definition of integrative oncology. And the parts that I just want to highlight is that we use evidence to inform our decision-making, which is a little bit different than the evidence to base. And it's really meant to be used alongside. So evidence informed, a good thing to think about is look at the safety and the risk profile of the intervention. If it's something like eating blueberries or doing yoga, very safe. If it's getting an IV infusion the same day as your chemotherapy, you probably want a lot more evidence to do that. And the alongside is pretty key because there is some data showing that women that have early stage, potentially curable breast cancer that forgo their conventional treatment have worse outcomes. So an integrative approach is a holistic approach, looking at what you're going to do for your body, mind, and spirit. And my challenge for you today is to think of it in reverse. What are you going to do for your spirit, mind, and body? Since so much emphasis seems to be on the body, how can you nurture those other aspects of yourself? When I meet with women individually, I tell them to think about it like a wheel, and you want to put as many spokes in that wheel as you possibly can. I think this highlights that it's not just about one thing that you're doing, and it also opens up the space that there's a lot more that you can be doing just than the sort of prescribed treatment approach. So the Institute for Cancer Research and their worldwide partner, the largest organizations doing research on diet and lifestyle for cancer prevention. But if you look at the bottom right-hand corner, it says after cancer diagnosis, follow these above recommendations. And I won't read them all out because you can see them. But these are all very strongly evidence-based recommendations. So a little bit about diet, and I want to highlight a couple things. I think right now in our culture, the big diet is a ketogenic diet. And is this the right thing for a woman going through breast cancer? And so the WINS trial looked at a good sample size of women and looked at was a low-fat diet compared to controls. And these were women that are done their treatment and they followed them for 5 years. And what they found was that a low-fat diet compared to the standard American diet reduced incidence of cancer recurrence. So across the board, about a 25% reduction in breast cancer recurrence. And as you can see, it's very interesting that the estrogen receptor negative had the best outcome with this. So really of what we know right now, the best dietary recommendation is a plant-based whole food diet. The plate on the right is something to think about, having more plates like this, where you are going to get some plant-based sources of protein. Definitely favor brightly colored and strongly flavored fruits and vegetables. This is how you're going to get more of the phytochemicals, also called phytonutrients. And the recommendation is really to stick with getting that from food rather than from supplements. My slides will be available to you, but I wanted to give you a couple of websites that you can go to for more information on diet and cancer. And also note that we do have dietitians available if you're looking for one-on-one consultations. A little bit on herbs and supplements, which is very hard to generalize to a large group. First thing is, can I get this from my diet? So if you're looking at a garlic supplement, you can easily get that from your diet, and I would tell you to get it from your diet. I would tell you to avoid high-dose vitamins. So when you look at the back of your supplement bottle, on the nutrition box in the right-hand corner, it will give you a percentage number with RDA. That is the recommended daily allowance. Ideally, it would be 100%, but many vitamins on the market are upwards of 1,000, 2,000%, and the safety around that is not very well known. If you are working with an integrative practitioner, ideally, they understand what your conventional cancer treatments are, And they also understand changes in your lab values, other symptoms and side effects that you might be having, as well as other procedures, surgeries, and interventions that could pose risk depending on what supplements you're taking. Everyone should look at your bottles and look for these stamps called the GMP or the NSF stamp. And this allows some confidence that these supplement brands have met the basic manufacturing and sanitation guidelines as outlined by the FDA. And then a great way to assure a high quality brand is consumerlabs.com, one of my favorite websites to recommend. And consumerlab.com has, for several different vitamins and supplements, it gives a list of brands, pictures of the bottles. And what they're saying is that for these brands listed on the site, they're guaranteeing that there are no contaminants, heavy metals, and what's on the label is in the pill. Memorial Sloan Kettering About Herbs is probably the best and the most robust site to look up information regarding different herbs and supplements as it relates to cancer and what we know and what things to take into consideration. The National Center for Complementary and Integrative Health also has great free information on herbs and supplements for overall health. It's not very specific for cancer, but it's very helpful, and they even have an app. So a quick word on exercise. The DELCAP study, which was a study looking at diet, exercise, lifestyle for cancer prognosis. What it found was that exercise during and after breast cancer diagnosis resulted in a 55% reduction in the chances of the cancer returning, which is pretty impressive. So exercise is a very instrumental intervention to be utilized. There's research to say it is the #1 thing you can do to help fatigue that comes up during and after treatment. And women who exercise throughout their treatment tend to have less side effects kind of across the board. So we have physical therapists, you could get a trainer, and we also have exercise counseling at UCSF Cancer Center, so reach out if you need more resources. A little word on sleep. It is very important for your health. I think a common thing is if you wake up to go pee or you wake up from a hot flash, as long as you can turn over and go back to sleep, it's not a problem. It's when you wake up and you are unable to fall back asleep that problems can arise. And the data on the benefits of sleep is also connected to the circadian rhythm. And so we understand that we have an internal clock that regulates a lot of our physiologic functions, our organs, and our hormones. This is why when you fly to a different country, you get jet lag. So going to bed and rising around the same time puts our clocks in sync and our bodies do better. Eating times also can affect health outcomes, so not eating late night. And there is evidence to suggest that women who work night shift have higher incidence of breast cancer. So sleeping when it's dark, being awake when it's light does impact outcomes. And then, you know, what to do with all of the thoughts and emotions that come up with the diagnosis during treatment and after. And this is where resiliency comes in. And this is a quote that I love. It's not the load that breaks you down, it's the way you carry it. So it's not the stress, and you don't always have you can't always impact the stress, but what you can impact is how you cope with it. And this is where you want to try to think about incorporating more mind-body modalities. And this gives you a couple examples of what is meant by mind-body modalities. This list is not exhaustive, but I encourage you to think about these and see what are some of these modalities that you could incorporate more. The mind and the spirit definitely overlap. Think about the things that you like to do to relax, positive coping skills, not negative. A challenge is what can you do for stress besides exercise? I think the top two things I hear from people are, oh, I exercise or I like to be in nature, and both are awesome. But how can you expand your toolbox, and what other mind-body modalities can you incorporate? Increase your use. This is how you cultivate resiliency. There is a lot of robust data in the neuroscience world that just practicing mind-body modalities is how you increase your coping. And be creative, don't overthink it, but a key is make it a habit, because the more consistent you are, the more you will benefit from the results. So basically, when you start to have emotions like this, or thoughts that evoke this kind of feeling, what can you do to evoke this kind of feeling? And so the Society for Integrative Oncology has put together some integrative practice guidelines for breast cancer. I will say that it's pretty conservative, because they only looked at randomized controlled trials, but it is very reliable of the guidelines that we do have. So most of the stuff is recommending mind-body modalities. There is pretty robust data that it can help with anxiety, depression, stress reduction, and mood-related changes. Meditation and yoga by far are the best to improve quality of life or overall well-being. Acupressure and acupuncture are recommended for chemo-induced nausea and vomiting. And when these guidelines were published in 2018, since that time, we know now that there's more data coming out about acupuncture and sleep after breast cancer treatment, but even potentially peripheral neuropathy. And in randomized controlled trials, there is no strong evidence to support the use of dietary supplements. It doesn't mean that you cannot use them. I think it's what you're using and the timing of it that's pretty key. And then I'll wrap up pretty quickly. So a little bit about the Osher Center. Some of the services that we have, I think the most common ones that people are interested in are acupuncture and massage. We offer a variety of classes. Most of them are currently online. We used to have a lot more in person. So when we get to the other side of the pandemic, we will resume them. But check out our website and see if there are any classes that you would be interested in. And certainly we offer individual consultations, as well as Dr. Abrams does a 3-part group series if you're just looking for some refinement information, but you don't need that one-on-one ongoing. And I did put the main number so that anybody could call interested in getting more information or having consultations or access to these services. Anybody can call this main number. And I'll leave it at that so that we do have time for the questions.
Welcome back, everyone. So we have enough questions, and Dr. Chien and Dr. Goldman, if you want to join us on screen so you can see all of us together. Well, I'm going to begin by asking some of the questions that people have asked, and I want to just say a couple of things first. Number one, I'm going to shift some of the questions away from individual treatment decisions, because those individual treatment decisions really need to be made by you and your physician, and that we will talk about those things in a general kind of way, like what are the things that go into making those treatment decisions that are particularly individualized for you. I also wanted to say, while there are a lot of resources at UCSF, some of them are restricted to people who are actually getting their care at UCSF. So you need to be a UCSF patient in order to access individual nutritional counseling or individual exercise counseling. But a lot of these educational events are open to everybody. And we will, once we put together this recording, we will let all of you who have attended know about how to access it so you can share it with other people. So taking a look at some of the questions that have come in, and I'm going to start with you, Dr. Chien, but if Dr. Goldman or Kathleen have anything to answer about this first one. This is about hair thinning. After all the meds are done, does hair thickness go back to pre-breast cancer? And what solutions have you come across for hair thinning? So you want to start, Dr. Chien?
Yeah, this is a tough one. So I would say by and large, hair comes back for almost everybody. And I say almost because there are certain chemotherapies such as Taxotere, where there is a small risk that the hair won't fully grow back. We now have scalp cooling technologies. There's different products. Here at UCSF, we use DigniCap, and many patients still rent the Penguin cold caps, and we support their use. And those are really effective technologies to help preserve hair. And I would say during some chemotherapy regimens like Taxotere, Cytoxan, we can preserve, I would say, more than 2/3 of patients can preserve more than 50% of their hair. With anthracycline containing regimens like AC, the success rates are slightly lower, but definitely we've had great success with both regimens. I would say in terms of hair regrowth, no matter where you're starting from, I have not seen data that supports any product in particular. I know that patients sometimes use biotin or Latisse for eyelashes. I can't say that I have any experience or data evidence-based recommendations, but anecdotally, I've heard that some patients have found it helpful.
Kathleen, do you have anything you would like to add?
Yeah, I think the number one thing I see is biotin. If you look at the data, there's no data for hair. It's actually for nails. However, I think that it's reasonable to try once you're done with your treatment. Although I will say that on the skin and nails, it's for 3 to 6 months. And it can interfere with certain labs, such as thyroid function and troponin levels, which are typically drawn if somebody presents at the emergency room and they think they might be having a heart attack. So I think a general rule would be to stop the biotin a week before any labs. And then just real quickly, there's a lot on social media. I don't think that those things work very well. And I think you have to be very careful because they're multi-supplement things. Are they safe with whatever other medications you're on? So those are the things you have to think about.
And I just wanted to add one thing, which is the diversity of people's experience with hair loss and hair regrowth is not something that we fully understand. And I think there's an intersection between people's family history around, are there a lot of people in your family who have prematurely become bald, and other issues in that way that nobody has really done the research to say this pot of people may be at more risk for having their hair grow back in a fulsome kind of way. So we don't have a full answer for that, but that's the thinking that we have at the moment. So specific question, Dr. Chien, can you discuss Verzenio in early stage hormone positive HER2 negative people?
Yeah, so Verzenio is abemaciclib. It's a CDK4/6 inhibitor, which is a targeted oral therapy that is approved in the metastatic setting for hormone receptor positive HER2 negative disease. And it's highly effective. It helps reverse some of the hormone resistance we see in the metastatic setting. It can nearly or double the time that the disease is controlled in the metastatic setting. So there's been a number of studies looking at this drug in combination with hormone therapy in early stage patients where they take it in the adjuvant setting. So one trial in particular, Monarch E, looked at hormone therapy plus abemaciclib versus hormone therapy alone. And there's been 2 presentations, and the data is very early, so it's very immature, but they reported out at 2 years. And at 2 years, still half the patients who were in that study were still on drug. So it's just a very early readout. At that point in time, they did see a small benefit in the patients who took the abemaciclib, and that benefit is on the order of 2 to 3% fewer recurrences than those who didn't. So I would note that you had to be high risk to enter that trial. So for ER positive patients, you needed to have at least 4 or more nodes positive. If you had 1 to 3 nodes, so you had to have positive nodes. If it was 1 to 3 nodes, your tumor either had to be at least 5 centimeters or high grade. So they were really selecting the patients who they thought had the highest risk and had the most to gain. I think we really need to see how this plays out. There's been other trials like this with other drugs like palbociclib, where at the 1 and 2 year mark, they saw these little gains, and those gains went away by 5 years. So it's not clear. It may be that we are delaying recurrence, and I actually think that is a meaningful endpoint as well. And ultimately, we want to see that it improves survival. So if you get it up front, and if you do still end up getting a recurrence later, can you still benefit from taking it when you have the recurrence down the road? Or is that benefit now shifted forward? So to answer the question, I say it's very promising. I think of any drug in the ER positive setting, the CDK4/6 inhibitors are going to be it. It's just whether or not we can prove it in this trial. And we'll have to wait for the 5-year update.
Thank you. We have a comment from one of our people out there in attendance world. A comment that pelvic floor physical therapy helps tremendously with painful sex. Wanted to share, and I wanted to ask Dr. Goldman to respond and comment.
So I entirely agree. I had presented that on my slide, but it was towards the end where I knew I ran over. But I think that for a lot of people that have pain with sex, what happens is that as that pain is persistent over time, there's a lot of anticipatory pain. And when you anticipate it's going to hurt, sometimes the pelvic muscles also tighten up. And there are certain things that we look for when we do a pelvic exam to assess for pelvic floor dysfunction. But working with a skilled physical therapist who specializes in pelvic floor physical therapy can be incredibly useful. And I also really am a big proponent of vaginal dilators, because those also allow for women in a non-sexual setting to figure out what hurts and what doesn't hurt. So entirely agree with that.
Thank you. Now, I have a question here that probably we could spend all day having a conversation about where we land with it. How much do you think positive thinking and spirituality affect the outcomes of women diagnosed with cancer? And I want to say a sentence before I pass it over to Kathleen to begin the reflection, which is, positive thinking can be an important way to be working with reframing what's going on in your life, whether it's cancer or other stressors. It can also be an extraordinary pressure cooker on you to be positive when you're not feeling positive. So I think I'd like to reframe the positive thinking to authenticity of real human feelings that you have and how you work with those. But I would like to bring my colleague and friend Kathleen in on how you would address this question.
Yeah, it's a really great question. And you're right. We could probably talk. I could say so many things about it, but I do want to echo what you're saying. And I think one of the pitfalls of this, you have to be positive all the time, is that if negative feelings come up, that somehow you're going to trigger cancer cells. And that's just simply, we don't know that to be the case at all. I think the science behind the positive thinking shows that when you are stressed, certain areas of your brain get hyperactivated, namely the amygdala, and that is where emotions of fear, anxiety, and depression live and thrive. So when you do things like gratitude or mind-body modalities, you're shifting out of the amygdala into other parts of the brain that bring about more, I guess I would call them positive emotions. Another way to frame it would be coming from a mindfulness, staying in the moment, but being open to everything that's coming up, positive and negative, and not being attached to either one. Because just like the clouds in the sky, it's going to change and it's going to pass. So I think spirituality is an anchor to your ship when the storms are rough, or a life vest that is going to help to keep you afloat. That's how I'd like to frame it.
Mm-hmm. Thank you. I would like to, there's a question raised here about the age at which people should start mammograms. So this is a screening question. And in the setting of physicians who are ordering screening, as in Dr. Goldman, and in the setting of people who treat breast cancer, Dr. Chien, the minimum age for a mammogram is age 40. And this is from a woman whose diagnosis happened at her first mammogram at age 40. And she's concerned that we should reduce the minimum age in order to catch more of people with her story. And I'd like to hear both of you reflect on what we're trying to figure out about mammogram screening in the wisdom study or in other contexts. Dr. Goldman, would you like to address that as a
Sure.
primary care physician who would order mammogram?
Yeah. You know, first of all, one of the things to realize is there's a lot of confusion out there, even for physicians, because there's a lot of different guidelines depending on different national organizations, meaning the American College of Radiology is different than the American College of OBGYN, is different from the American Cancer Society. Certainly after 45, all of the large guiding organizations do recommend screening. 40 to 45, although many do recommend regular screening, what people talk about is the shared decision making, which is rather than let's just order a mammogram based on your age, let's really sit down and talk to you about your risks. Have you had problems with your breasts? Have you had prior breast biopsies, and what did it show? Do you have a family history? And I think some of the time people don't take the time to take the appropriate history so that they can make appropriate shared decision making. Some of the other issues is the younger someone is, the more dense breast tissue there is, and more often mammograms can miss cancer. So 10 to 15% of the times in the setting of dense breasts, we may miss cancers. So it's not a perfect test. There's a lot of questions. You have to balance out how frequently and getting mammograms and false positives. There's also false positives that lead people to be called back for painful tests and things that make them anxious. So there's a lot of kind of questions about when to begin, how often to do it, but generally 40, for most of the large guiding organizations, 40 to 45 shared decision making. Under 40 really hasn't been shown to be much of a benefit, and above 45 is a benefit, and beyond 75 not clear. And I'll let Dr. Chien give you her thoughts though too.
We're having a little audio difficulty. You're fading in a little bit. So I think our internet is a little unstable. Dr. Chien, do you have anything you want to add about the mammogram question?
No, I mean, I completely agree with Dr. Goldman. I would just make one plug for the Wisdom study, which for those who are not familiar, is a trial that's really trying to get at this question. It's looking to see whether an individualized approach to screening is better than a standard recommendation for a population. So this trial, you actually get to choose, do you want to be have individualized recommendation for screening based on your genetics, your history, or do you want to just follow the standard recommended guideline? And then they're following these patients. So that's something that if you're interested, patients are interested, I would really look into. The other thing I would say is that many of our young patients present with what we call interval cancers. So even the ones who are getting the annual mammograms, because these are younger patients, and as I showed you the data, these tend to be more proliferative and often triple negative or HER2 positive. And they literally do develop in between your mammograms, interval cancers, because they are so highly proliferative. And so that's the issue with the mammographic screening recommendation for young patients in particular, because the people who make the guidelines are obviously looking at a population level and saying, are the mammograms really picking up the cancers that are that are the most clinically relevant for young patients? Because many of them actually don't present on mammogram. Patients come in because they felt a mass in between mammograms. So
thank you. There's a question here about recommended resources for people who are interested in keeping up with the results of UCSF trials and research. And the answer is yes, we will send you out resources. Dr. Hope Rugo does a quarterly meeting that invites different speakers to keep up on new research and trials, and that will be part of the ongoing information that we send you. Dr. Chien, there's another treatment question here. All right. So how would you address the question, and this is for Dr. Goldman and Dr. Chien, really, about how to do decision-making about safe pregnancy? So in terms of the kind of conversation you might have with a woman about her treatment story and when to decide that it's safe to do pregnancy, how would you address that?
I can start. I think this is also, like everything, very individual. As we alluded to, there's no data right now that the pregnancy itself increases risk of recurrence. The research around that obviously is retrospective and observational, because we can't randomize patients to pregnancy or no pregnancy. And so certainly all of that research, there's a selection bias, because only patients who are doing well will try to get pregnant and embark on pregnancy. So, but in those populations, we're not seeing increased risk of recurrence compared to breast cancer patients who don't get pregnant. But the question about whether there's additional risk associated with interrupting hormone therapy is unknown. We're actually doing a study here at UCSF to understand patients' willingness to take that risk in terms of interrupting the hormone therapy if it increased the risk of recurrence by X amount, because this is really unknown. We don't know what that increased risk is. There is an ongoing trial called the PROMISE trial right now, where patients are allowed to stop hormone therapy after I think it's 18 months. They have to have had been on hormone therapy for 18 months, then they can come off hormone therapy and get 2 years to try and get pregnant, carry the baby, deliver, and then the idea is that you must go back on hormone therapy after 2 years. And these patients will be followed. It's a single arm observational study to just understand what the risk is. So, I think it's individual. It's based on how old the patient is. It's based on whether or not the patient has any eggs or embryos banked, whether or not they need to or want to try naturally first, what their underlying risk is from a breast cancer standpoint. And I generally will have a very open and very clear conversation with the patient so that we understand what we know and we don't know. And ultimately, our goal is for patients to have full lives after breast cancer. And for better, there is some time sensitivity to this decision. So for many patients, I am supportive. If they understand that these are the unknowns, they've done at least, in my opinion, 2 years of hormone therapy, to take a short break if they're, relatively low risk, and then go back on. It's an individual decision and shared decision.
Mm-hmm. Dr. Goldman, do you have anything you'd like to add?
The only thing I'm going to add is some of the specifics that I talk to patients is once the oncologist has given the okay to stop hormonal therapy, and someone has a washout period, what I do talk to people is how long to try on their own versus if they have frozen eggs or embryos, because certainly the goal is to get people back on their hormonal therapy, with 2 years really being the max. So it's not the same as in the general population where we will say we don't give a diagnosis of infertility until someone has tried consistently for a year. At the most, we will usually say, if you want to try naturally, and some of this depends on looking at what someone's own fertility reserve is. We can check hormone levels on certain days of their cycle. Ultrasounds can be used to look at their antral follicle count, but it will give us a sense of how long to tell someone to try on their own before going ahead with using frozen eggs or embryos. And then I also work closely with the oncologist, because if the oncologist's goal is to get someone back on their hormone therapy as soon as possible, we may say, have your washout period and immediately go work with the fertility docs to do assisted reproductive techniques rather than trying on your own.
And while you're on the screen, before you mute yourself, which you did already, who would you recommend that people see medically to treat sexual pain and vaginal dryness? Would it be their own gynecologist? Would it be, depending on what system they might be in?
Yeah, so in general, I would recommend seeing a gynecologist. There are some primary care folks that may feel comfortable managing that, but most times vaginal pain and sexual dysfunction is something that most gynecologists will manage. There are some places that have even subspecialists within GYN. We have both IC survivorship patients, and we have another provider on our faculty, Dr. Tammy Rowan, and her specialty is actually sexual dysfunction. So depending on what institute you're in, I'd start with gynecology and then ask your gynecologist what their experience is or whether they have a specialist that they refer to.
So I am very well aware that we haven't answered all of your thought-provoking and important questions. We will, as a group, look together at these questions and try to address them as part of our follow-up. We encourage you to have these conversations directly with your treating physicians if they are specific questions about how this applies to your care. And I would like each of our panelists to reflect on a final question before we close the evening and the webinar. And the question is, will I ever feel normal again? And from your own perspectives of working with people, I would love to hear your reflections on that as we close out our evening. Kathleen, why don't you start?
Wow. Not to be an antagonist, but what is normal?
Right.
But I'll just draw from my own personal experience as a stage 3 breast cancer survivor. It gets better. It does get better the further out you get. As simple as that.
And if you wanted to say a sentence about what's the content of the "it gets better"?
I guess I think a lot around the initial, I'll say like a specific, like the initial going into early menopause with chemotherapy. I definitely want to echo what Dr. Goldman said, that I think I mean, I only know myself, but it was pretty extreme. And then the longer I went, even with the hormonal medications, it subsided kind of on its own. And the longer years and years, like it did sort of get better. So I think the further out from treatment you get, I do think the easier things do become.
So this is the world of what we're calling survivorship, and your reflections, Dr. Chien?
So I agree. The question, what is normal, is actually not a rhetorical one. I think that what I can say about observing my patients' experience is that absolutely I have patients who come in saying, I'm happy. There are days I actually don't think about breast cancer. And, their normal may be a new normal. Do they go back to where they were before the breast cancer diagnosis? Probably not exactly, but do they get to a place where they have happy, productive lives? Absolutely. That's just, my observation from my patients.
Dr. Goldman.
You took some of the words exactly that I was going to say, Dr. Chien, but in my experience, oftentimes it means setting a sort of a new set point. But what I find so exciting about working in the survivorship world is, whatever 20, 30 years ago, people were so much more focused on just, is this patient going to live? And now we have all these wonderful treatments that people can live for, long periods of time, and how they live becomes really important. And so we're finally starting to see good studies going on looking at survivorship, and we're coming out with more and more options to treat things like hot flashes and sexual dysfunction and mood issues. And so I think it now is so much of a better time because there are so many things to allow people to have a really improved quality of life. And also in my observations that it may be setting that new set point, but that people really do get back to a place that they're feeling good much of the time.
And I'll just add one more thing. I sometimes will match up some of my patients, especially the young ones, with everybody's consent, of course. And, I have a plethora of patients who are, so generous and interested in being sort of a mentor or a buddy for any patient who is newly diagnosed. And when I think about who to match who up with, these patients of mine are happy and they're leading full lives and they've had their unique experiences. And it's really rewarding and joy for me to say, gosh, like this person would be such a helpful mentor for this new patient. And there's so many of the patients I can choose from to match up. There's just too many for me to, match everyone up. But it's just a reminder that where you start is definitely not where you end up. And there will be one day where you may be that person who wants to be the mentor for somebody new because you're doing so well.
And I would just add that the connections between women who've had like experiences are communities that get built. And sometimes it's formally in a support group. We have a young women's breast cancer support group. that I co-facilitate with Dr. Anna Levin. And there are other resources in other settings if you're not at UCSF, community-based support groups, but also people reaching out to other people one-to-one. And I would say, and this has been a super challenge during COVID, but finding ways to break down the isolation and the sense of aloneness and the sense of going through this on your own, and looking for the kinds of supports that resonate for you in your life as you go forward. And I think I want to add one other thought, which is, I think if you look at the beginning of the breast cancer diagnosis and the time frame at the end of it, even if you hadn't had breast cancer, you would have life changes happening over time. And this, I say from my retired gray-haired perch, that there are changes over time in a lifetime that are a piece of survivorship, the things you grow with and learn and add to your repertoire as we go. So we will try to be in touch with you about some of the questions that remained unanswered. We are really, really happy that you joined us tonight. And Kaylee, who's here, will be in touch with you by email about how to access this particular webinar if you're interested. Stay tuned. We will be doing future webinars on different subjects. And thank you so much for joining us tonight, and take care. Bye, everybody.
Bye-bye. Thank you. Thank you, Debbie.
Good night, everyone.
Good night.